Thank you. Thank you so much. It's really an honor to have an opportunity to spend this day with you. I feel like I'm talking to a lot of people I've known for a long time who have played really critical roles in our understanding of the science and how that science has informed, or in some cases not informed, policy, and how that policy has been translated into programmatic strategies to impact the morbidity and mortality on the planet. I actually have a series of slides that are more to give you to see the quantitative impact of the response to HIV globally. I'm going to zip through them very quickly, but I just wanted to echo what Jaime really very eloquently stated in his opening remarks. It really is about our ability to take the science and apply it to those who need it. For those of you who have developed strategies that have not had application, it is a tragedy, but it is also common that the ability to maximize impact and have the drop in mortality that was intended or in the suffering that is evident is more often not realized on a global scale. Most people who are burdened by the disease do not get in front of the diagnosis or the treatment. That is still the norm in every country we're in. And it has been a breathtaking honor to be a component of the motor that has allowed to align those disparities. PEPFAR has been, as Elvin said, one of two large motors on the planet that have brought resources to bear to try to narrow that disparity for those with disease and the ability to diagnose and treat it. We started the PEPFAR program in 2003. President Bush had the courage to take the leap to do what he was virtually not being advised to do by any of his advisors in the political realm. But it was the scientific rigor that persisted that enabled him to find a window to put forward an allocation that Congress did fund and really did allow for the first foray into very resource-poor settings to put the ability to diagnose and treat a very complicated disease. The belief that that could be done was not present, and I would say that President Bush did step into this space, and that took some political courage. I think that PEPFAR in 2003, there were only 50,000 people who were being treated in sub-Saharan Africa. 72% of the epidemic was on the continent, and that did not change. It was mainly military elite and political elite, wealthy, who were receiving drugs largely from Europe, and that 50,000 number has now exceeded 10 million. The numbers in 2008, which is when we started to pick up program, that President Obama's administration started in 2009. So from 2009 to the present, we will exceed the World AIDS Day target, which will be announced December 1st. We're in the mid 6 million range now, and it will continue to grow for another month and a half. This has been with a 12% drop in funding over that time period. We have had flat or dropping funding. The first year it went up a little bit, then every year thereafter it dropped, and again a 12% drop. We were able to do that by being smart about our ability to bring resources to bear, to buy at scale. The help and work of many organizations allowed that to happen, both in the pharmaceutical arena as well as in multinational NGOs like the CHI program gave our ability to maximize the unit purchasing. We went from what was about 37% generic in 2009. We're now at 99% generic. That saved hundreds of millions of dollars. We went from global air transport of pharmaceuticals and commodities, laboratory commodities, to ground transport. That saved another hundreds of millions of dollars. Our management structures, instead of having one manager for each clinic site, in the thousands of clinic sites that have been put up with this program, we went to aggregating one manager for 10, one manager for 20 sites. Those types of really common sense, simple alterations in the way we implement the program resulted in our ability to take those savings and pour them back into program to allow for us to expand on every front. The treatment expansion was dramatic, and that was the one we focused on the most because of its impact on incidence. But we also had similar expansions in testing. We, in 2012, tested 50 million people globally. Out of that 50 million people in that 1 year tested, we found 770,000 HIV-positive pregnant women. And of those, we started them all, or about 98% of them, on antiretroviral drugs that resulted in about 230,000 infections prevented in the babies. That type of scale has been what PEPFAR and the Global Fund have brought to these countries, to these continents, and it is in our now planning and implementing together with the Global Fund that we will realize another ratchet in savings. Hi, Nancy. Come on up. Good timing. I think that in terms of pregnant women, in 2008, 2009, there was really not a concerted effort in the early stages of PEPFAR to create PMTCT strategies. They really started and robust in 2009. We have continued to grow that. It's been a struggle, and we'll talk to some of those issues. So the global programs really showed the planet that you could throw resources, large amounts of resources, at a problem and have a profound impact. The question of whether or not that impact would be sustained and whether or not the individual programs would be integrated into the delivery systems of the country, because we largely initially set up parallel programs that did not interface with government. And as a result, it put the United States in a direct relationship with patient care without, as I say, a government between us and between the United States and a patient. That kind of ethical relationship necessitated a very different dialogue as we came into PEPFAR with government. Indeed, it was often the first time the governments had been spoken to government. Early PEPFAR used the implementer as the interface with the Ministry of Health and kind of setting up the arrangement more than later kind of PEPFAR 2 has done. That has resulted in the programs moving from largely parallel systems of care to now, we are now almost 100% local partners in countries, have shifted back to public hospitals and clinics. I think it allowed the science to be delivered in a way that it had not been before, again, not in pilot sites, but to scale, not just in the capitals, but moving into the rural settings. I think that our ability to do this is really nicely reflected in what we call a programmatic tipping point. This allowed us to put together a variety of interventions that resulted in a drop in the number of new infections and talk to the Office of Management and Budget and people in Congress to conceptualize kind of where we are in the appropriateness of our programmatic interventions. Are we on track or off track in kind of a gestalt or some under the curve kind of fashion. It's been a very helpful tool for us to continue that discussion with leadership in countries. And we are now moving into the, let's see. Anyway, the yellow bars, we're now moving into yellow bars with South Africa, Cote d'Ivoire, Mozambique. Uganda has dropped down again now in the recent data. And then the others, Lesotho has dropped down significantly, but the others have stayed pretty much where they are. We're approaching 20 countries now that have hit this tipping point. This is at 350 CD4s. This is just another representation of the same data. The same with PMTCT, going from the bottom right up to the upper left. These are dramatic movements over the time frame that we've been talking about. 13 in PMTC has been our most rapid year of movement. So this will look very different in the next, when we do the calculations for the next step. We tried to put this into a narrative that allowed, again, policymakers and congressional appropriators to understand what and where we were in this evolution. This has been a document that has allowed, I think, for further buy-in, even from very conservative elements in Congress, including the Tea Party, to again see how their dollar is buying not only an individual's life turned around and restored and saved, their family, their community, their society, but we've also tried to correlate how that social stability minimizes the threat for terrorist activity and for continued economic growth. And those are areas that need further research. These are the elements on the roadmap, broad kind of swipes of scale-up impact interventions, our ability to show those that are high impact, PMTCT, male circumcision, and treatment, the role of testing in creating a demand for identification of HIV positives and entry into systems, the development of cascades from testing to staging to initiation of ARVs, and the continuation and sustaining that ability, the geographic relationship to that cascade, that it's different in different areas, and the kind of aggregate understanding that should go into a planning process, both for program and budgetary reasons. We look at each country on the way the baseline on the blue, how the current combination prevention portfolio, it's different in each country, drops number of new infections, and then looking at how change from 350 to 500 will continue to maintain this lean forward programmatic tipping point that we've talked about. We do this, each country's different. In Kenya, a different epidemic, different motors in that country to identify and take advantage of. Uganda was going in the wrong direction in end of 11, early 12. Their incidents started to flatten out and go up. It was because they stopped putting resources into treatment, and their testing motor had also stopped to drive new patients into the system. The elimination of PMTCT has been a dramatic drop in the last year, as I have said. We, with UNAIDS, have joined in an initiative to virtually eliminate pediatric AIDS. By the end of 2015, we expect to be somewhere around 30,000 infections annually. Right now, it's about 430,000 babies being born. This was actually in 11. 430,000 globally on the planet. 78,000 of those babies were born in Nigeria. The majority of the rest were in South Africa and in 6 other countries in sub-Saharan Africa. We took 22 countries to target for this effort and have put significant sums of money starting in 2009 into these countries to develop and monitor our ability to create the cascades, stop the leakage, and has been a big part of my time over the last 2 years. our efforts are the main efforts on the planet for this. My belief is that somewhere around 2015 to 2016, we will basically reach people, women who are in care, prenatal care. The persistence of the 30 to 40,000 will be because we can't identify, enter, and retain those women. The cascade, well known to this audience, I won't belabor it, but this is how we think of it and how we look at each delivery system in each geographic setting and get very concrete about how we understand this and where it goes. Malawi is an example of a move to B+, and the dramatic rise in the number of new individuals getting antiretroviral therapy happened over a very short period of time, months, and has persisted. So I think it's a wonderful example of matching up a high-impact intervention in a willing and capable delivery system. We have not done well with pediatric HIV. We didn't do well in the United States with Ryan White. We had the same lag with pediatrics, but we caught up, and in the global setting, it is also the same. Kids are hard to identify. We're dealing with cultural insensitivity to a child's death, is the way I would say it with this group, and the willingness and ability of delivery systems to identify children is a new idea in all the countries that we're working in. We have framed this in many of the countries and are now, over the next period, the next 4 years of PEPFAR, you will see a dramatic increase in number of children identified. CHI has played a critical role in on the planet to generate these numbers in the early years. They, with Unitaid funding, really were the main motor, and PEPFAR. But now we've made it a priority, and we will be able to pick up the CHI children that they have in each of the countries and to move into a cooperation with the Global Fund that is unique and will be focused on pediatric treatment. The role of voluntary male medical circumcision, took us a while to get convinced of it, and all of the data really showing that to ignore this intervention is a mistake. We had to create demand for male circumcision in countries which required movement into new interfaces with media, with couple counseling, and with, I would say, marketing. Our best successes have come from Madison, Fifth Avenue type of marketing strategies. They've been very effective. Zimbabwe in particular, South Africa, Tanzania now have had, in the last few months, a real rise in their male circumcision strategies. We've gone from kind of one at a time in an operating room early on to now kind of MASH units that kind of move like a carnival, plop down, stay there for 6 weeks to 2 months, and move on. In targeting the partner, the woman, has been the most successful strategy with that. So the smart investments, tuberculosis, we have put a huge amount of resources into TB HIV. We are by far the largest effort moving in that direction in terms of program. We've got ways to go. I've made this a strong priority in the last 4 years, but we've only scratched the surface. We are positioned in 13 funding, 14 and 15 to crescendo with TB diagnostic capability, as well as targeting the use of INH prophylaxis and other strategies to really move this agenda faster. We have a disease that can be diagnosed and treated and cured that has not benefited from this type of scale-up. The comorbidity, I won't tell this crowd about this. It is good on all fronts to target TB, and we're trying to do that more aggressively. So the lower costs, the financial and economic data to establish partnerships that allow for us to make strategic decisions on what our investment specifically and where that investment is, how that informs or results in an increased impact, the outcome. We have done expenditure analysis in 22 countries. We will complete 36 by the end of next year. It has been the single best tool that we've come up with to maximize our dollar and pay for things that work and not pay for things that don't work. I would say if you asked me what enabled us to increase by 5 with a 12% drop in funding, this is what it was. It was the expenditure analysis. Yeah.
Are you nearing the end?
Yeah, so let me just wrap it up. I actually have more slides here than made sense, but I would want you to look at them as you move forward. I would just say that the attempt that we had to match the programmatic movement to scale was also matched with an attempt to focus on our colleagues in country to try to change and support the evolution of a cadre of clinical expertise in our academic medical centers in sub-Saharan Africa, change the curriculum, put a clinical faculty in teaching hospitals, have that faculty be supported with institutions like morbidity and mortality reports, grand rounds, chart reviews, etc. It has been dramatic, the networking that has occurred in and amongst each medical school and between medical schools. This matched with the accreditation of laboratories from the African Society for Laboratory Medicine and the nursing MEPI has put, I think, a gradient of pressure in supporting our colleagues in country to continue their excellent work and expand it, and to create a self-expectation in the medical profession of excellence and intellectual accountability. I am humbled by how dramatic this change has been in our movement from a syndromic approach, especially outside of capitals, of medicine, to now one of diagnosis and treatment, and propping up the academic medical center in countries to be that standard setter, but also to be the resource for national and provincial ministries of health to use that expertise in the academic medical center like we do in this country and in Europe. More commonly, it is now happening in Africa. So I think one of the most significant contributions we have made to anchoring this will be the MEPI-NEPI program. So I'm going to end with that.
Cool.
Yeah.
Thanks, Senator.